Greetings to everyone and welcome to this webinar session, which has been organized as part of the activities to mark the World Immunization Week. And so in partnership with the AORTIC, the Women's Health Program came up with this webinar so as to share with us the experience of Cameroon in HPV vaccination, specifically the experience of the Women's Health Program. So we have a host of people participating in this webinar, and I want to use this opportunity to welcome us all for this session and to say we will feel free as we go through the presentations and then take note of questions which you can share with us or contributions you can share with us in the comment section in the chat so that by the end of the presentation we can handle them. I don't know if we'll have enough time for each person present to introduce themselves, but I will say from my end, you're all welcome to this session. So we are going to have two presentations. The first is titled Expanding HPV Vaccination in Cameroon, and that is going to be brought to us by the Women's Health Program Supervisor in the person of Mrs. Manjuh Florence. And after that, we are going to have another presentation which will be telling us about the single dose vaccination in Cameroon. It's going to be brought to us by Mr. Ngalla Calvin, who is the Assistant Supervisor for the Women's Health Program of the Cameroon Baptist Convention. So that's what we're going to have this afternoon on this webinar. Thank you.
Good afternoon, good evening, and good morning to all who are on the call. My name is Manjuh Florence, and just like Kathleen has introduced, I am the Program Supervisor for the Women's Health Program of the Cameroon Baptist Convention Health Services. And I double as the Vice President for the African Organization for Research and Training in Cancer for the Central African Sub-Region. I am glad this afternoon to share this presentation with all of us. And I believe that it's going to be an exciting moment with all of us. The presentation is titled Expanding HPV Vaccination Coverage in Cameroon Using a Multifaceted Approach. So as an introduction, I want to talk about the Women's Health Program of the Cameroon Baptist Convention Health Services. The Women's Health Program of the Cameroon Baptist Convention Health Services started in 2007, and it has different components. The components for the Women's Health Program are, we are going to be seeing them, but I just wish to indicate that we have 13 clinics in 7 out of the 10 regions of Cameroon, and we do both remote outreaches to remote areas, and we equally have facility-based clinics. From 2007 up to now, we have been able to screen over 110,000 women for cervical cancer screening, and we have treated over 4,000 women for pre-cancers and referred some. Slide. So like I said, we have 4 components for the Women's Health Program. The first one is cervical cancer prevention, which is primary prevention and secondary prevention. So we go for cervical cancer screening and vaccination. We equally do breast cancer screening. We also have syndromic management of reproductive tract infections, and we equally have family planning. And following the World Health Organization strategy to eliminate cervical cancer, Cameroon, together with the Women's Health Program, they have had these strategies. That's a 1970-90 strategy
Yeah, the global strategy for the elimination of cervical cancer, that is 1790, involves vaccination, involves screening, and involves management of cervical lesions. And altogether, these three keys, they work towards the cervical cancer elimination as brought up by the World Health Organization. Slide.
Sorry, let me just continue. Okay, thank you so much for stepping in. Like we had earlier mentioned, we have primary prevention. And with primary prevention, which is HPV vaccination, we had some project that we have carried out in the Women's Health Program of the Cameroon Baptist Convention Health Services. The first one was in 2010 to 2012, which was a pilot project with the quadrivalent HPV vaccine. We had this vaccine donated to us by the Merck & Co, and we piloted it. We are going to be seeing the results. From there, we had to do a bivalent vaccine, which was from 2017 to 2019. We are equally going to have the result. And from there, we have continued from 2021 to date. We have continued with the HPV quadrivalent vaccination. Slide, please. So as an epidemiology, we want to say that Cameroon records an estimate of at least 2,770 cases of cervical cancer annually. And cervical cancer is the second leading cause of cancer deaths among the Cameroonian women. And as of 2021, only 13% of girls in the world are fully protected against cervical cancer through vaccination. And because of this, we had to think of getting into different strategies to see that the uptake is increased. Slide. For the quadrivalent vaccination pilot that we did in 2010 to 2012, like I mentioned, we had quadrivalent HPV vaccines from Axios Healthcare. And this vaccination project was targeting girls 9 to 13 years of age. And the number of doses for the girls were 3 doses, and all these doses were to be given within a period of 6 months. The approaches that we used during that pilot to get the success rate that we had were the health facility-based project, where parents had to bring their daughters for vaccination to the health facilities. We equally used the school-based approach. We went to schools and we gave out consent forms for girls to take to their parents, and finally the parents came and they gave the consent for these girls to be vaccinated. We had a community-based approach, and in the community-based approach, we had to get into the communities, work with the community head or the village head, and then get their authorization to work in their communities. So that is how we were working. And so at some of the times, we could do door-to-door vaccination. And another thing that we used during that time was a mother-daughter approach. And in the mother-daughter approach, the mother comes for screening at the same time, coming along with her daughter or daughters for vaccination. So we call that the mother-daughter approach, because in most of the communities, we organize screening campaigns together with vaccination. And many of the women that had lesions, maybe precancerous lesions, were motivated to bring their daughters to prevent them from such. And that's how we succeeded with the mother-daughter approach. Slide. This is the overall coverage that we had for the pilot. We vaccinated over 6,800 girls with 3 doses, and we had a 3-dose vaccination of 84.9, which is approximately 85%. Slide. So from this, the government of Cameroon had the opportunity to officially introduced HPV vaccination in Cameroon, even though they still had a pilot project in 2015. And after that, the HPV vaccines were authorized to be used in Cameroon. And from 2018 to 2020, the Women's Health Program had to go in for a bivalent vaccine to vaccinate both young girls and women 9 to 55 years old. And this was given at a cost of $21.4 per child or per woman or per dose. And for the girls who were less than that is 9 to 14 years, girls who were 9 to 14 years, they needed 2 doses of the vaccines. And people who were 15 to 55 years old, they needed 3 doses. And only very few, as we are going to see, that had to pay, were able to pay in this money to receive these doses. Slide. So as a total, we had 1,400. Sorry. We had 1,447 girls and women who took the first doses, and just about 843 who had to complete the 3rd doses. So these are the number of people we had for the bivalent vaccine. Slide. So the expanded program of immunization, which is one of the arms of the Ministry of Health for Cameroon, finally introduced the HPV vaccination, and this was included into the vaccination calendar for Cameroon. And as of September 2021, this was officially introduced, and the vaccines, we got donations, and these vaccines are given in Cameroon for free. The government of Cameroon targets young girls 9 years as of that time. And the approach that was to be used, especially with the government, which yielded very little, was the school-based approach. And with the school-based approach, the vaccines came at the same time when the COVID-19 vaccines were being introduced, and there was very little time for sensitization. And so with that, the school-based approach did not yield well in Cameroon. And so we had to resort to health facility approach with nurses. And even with the health facility approach, it did not go so well in those early days because the nurses that were to be given the vaccines were not trained to do this. Only a few of them were trained. And so that did not yield well. And like I said, the vaccines that we have are the HPV quadrivalent vaccines, and we have them still till today. And like I said, it's a donation through Gavi. Slide, please. So in the Women's Health Program, we had to establish different strategies to see that the uptake of HPV vaccination is improved. And we targeted young girls 9 to 14 years with 2 doses of these quadrivalent vaccines. And the approaches that we used to get these young girls vaccinated were, we had to use the school-based approach. And with the school-based approach, the Cameroon Baptist Convention Health Services is a faith-based organization, and it also has schools. So we targeted the Baptist schools around Cameroon, and we also used the health facility approach, where we kept vaccines at the health facilities and asked for parents to bring their daughters for vaccination. We equally use the community approach. And in the community approach, we went to different communities working with the community health, and we equally had to do door-to-door vaccination. We had the mother-daughter approach again. We had some donations from Together for Health, and we had to organize mother-daughter approach in some communities in Cameroon, where we had to do cervical cancer screening and vaccination. The last approach that we used was the church-based approach, where we had to involve the church leaders, especially the Baptist churches as of that time. We used the Baptist churches as an example to see if this will work well. So we used the leaders and that's the elders of the church together with the pastors, and we're able to get to these girls. Slide. So this is the overall result of what we had. We realized that the church-based vaccination yielded most. Out of about 10,000 girls that we vaccinated in 2022, we had 5,198 girls being vaccinated in the church or through the church-based approach. And we had the clinic and the mother-daughter approach coming in second. So the other school-based and community, the door-to-door did not yield so well. So we thought that the church-based approach should be expanded to see how it goes, because we think that through the church base, we can have a great uptake for HPV vaccination in Cameroon. Slide. In conclusion, we want to say that the expansion of HPV vaccination programs worldwide has led to a reduction in genital infection and has translated into significant decreases in the incidence of HPV-related outcomes. And as a result of that, we want to encourage HPV vaccination because we know it's going to significantly decrease the incidence even in the coming years. Slide. So as recommendations, we want to say that church leaders and traditional authorities are a great asset in HPV vaccination. If we truly want to succeed in HPV vaccination, we do not need to keep these people aside. We need to work with them. The church leaders, especially these times, and many of the Africans trust the church. They believe in the church. So we believe that if the church leaders are made to understand how important HPV vaccination is, they are going to incorporate it into their routine services or the church activities, and girls and women or people can be vaccinated, and we are going to reduce the HPV incidence. So we are encouraging the church leaders to be fully involved and traditional authorities to be fully involved in HPV vaccination. Slide. So these are just some pictures to show us what we had done, health facilities. We equally had to do sensitization using T-shirts, as you can see in the picture. Slide. Like I talk about church-based approach, these are nurses who have gone to different communities and vaccinated young girls in the churches. And if you look at the other picture where there is a man, that is a picture of a pastor sensitizing the community on HPV screening and vaccination. School-based approach, we visited different schools, we gave out consent forms, the parents signed the consent forms, and the girls were vaccinated. The mother-daughter approach, we went to the different communities. We talked to both men and women to get to understand and send the men to send the women for screening and their daughters for vaccination. This is what happened for the mother-daughter approach. Yeah, we want to end by saying that the task is great, but together we can do it. Thank you so much for listening.
Thank you, Florence, for that excellent presentation. If anybody has any questions, feel free to write in the chat. If you're not ready with a question now, we can always address it a little bit later. See no questions in the chat box. We can start with the next presentation if you are ready.
Yeah, greetings to everyone from Cameroon. As earlier introduced, I'm Ngalla Calvin. I work with the Women's Health Program as the Assistant Supervisor, and I'll be keying off from the other presentation, focus on single-dose HPV vaccination in young boys and girls, and experience from Cameroon. Slide, please. I'll follow this outline. Slide, please. So the objectives of this presentation is to provide a background about HPV vaccination in Cameroon, and also to state some benefits and challenges being faced with the introduction of the single-dose HPV vaccination in Cameroon. Slide, please. For a brief background, the HPV virus is a DNA double-stranded virus and exists over 200 types, with about 15 types infecting the genital tract, and could lead to various forms of diseases, some of which are malignant. About at least 70% of cervical cancers are caused by HPV type 16 and 18, and transmission is mainly by skin-to-skin contact. Next slide, please. Not only cervical cancer, you have a range of other forms of cancers that are being caused by the HPV virus, and you kind of see the benefits of HPV vaccination, which is coming to reduce the incidence and mortality caused by these various forms of cancers. Slide, please. This vaccine actually has the kind of virus-like particles, but it doesn't infect the individual, but could stir up an immune or antibody response once an individual is injected with this particular vaccine. And for now, we have different forms that are available worldwide. We have the Gardasil 4, which is currently what we are using in Cameroon, covering the 4 strands of HPV. We have the Rodrigues, which is bivalent, and it was being used in the CBC within the dates that was illustrated in the other presentation. And we also have Gardasil 9, which covers 9 strands of the high-risk HPV types that could lead to a wide range of cancers. This one is mostly found in some developed countries. Slide, please. The Women's Health Program, as earlier mentioned, was started in 2007 and has implemented various HPV vaccination projects, beginning the pilot between 2010 to 2012, where we had more than 6,800 young girls aged 9 to 13 vaccinated. We also have the Cervarix bivalent vaccination that was introduced between 2017 to 20, carrying on by the Cameroon Baptist Convention Health Services Women's Health Program, and we're able to vaccinate above 1,400. And we have the other Gardasil 4 vaccination that was introduced by the government, that is beginning September 2021 to present, and we have been able to vaccinate as of now more than 11,000. Slide, please. For the pilot, it included 3 doses, and as we mentioned, it was targeting girls aged 9 to 13 years, and you could see that right up to the 3rd dose, you could have a compliance of up to 84.9%, and for the 2nd dose, 95.1%, which was quite significant. So that was the kind of first evolution that was experienced with HPV quadrivalent vaccination in Cameroon. And then the next evolution, slide, please. Came up when the Women's Health Program introduced the bivalent vaccine, and people had to pay for So it was targeting young girls 9 to 14 years who were administered 2 doses, while adults aged 15 to 55 years were administered 3 doses, and each dose costed $21.4. Slide, please. Moving to the third dose, or the third evolution, beginning September 2021, we had the GADASI4 introduced into the expanded program of immunization of the Ministry of Health. And beginning January 2023, instead of the 2 doses that was administered at the time this was introduced, there was a switch to the single dose vaccination as recommended by the World Health Organization. So between January to March, the Women's Health Program was able to implement this single dose vaccination. And the figures are on the next slide. Slide, please. So we had this single dose vaccination that wasn't targeting only young girls, but also we had boys involved. And from the chart, you could see that the number of boys that were vaccinated covered approximately 34% of the overall population that had been vaccinated between January and the month of March. So a total of above 1,600 had been vaccinated this far, boys and girls. Next slide, please. Some of the benefits that we experience with the single dose vaccination involves being time and energy saving, because you may not have to visit a community or a particular area, whether a community, whether a church or a school, over and over. Once you visit and you save the vaccine, you're sure that you are done from that area and you could go ahead with the other areas. It also reduces the risk of loss to follow-up. By the time you administer a dose to a kid, before you know it, maybe the child has relocated to somewhere else or to another community, and to get them for the second dose could be very challenging. But with single dose, that is quite easy. By the time you vaccinate them, you're already sure they are covered. And there is high coverage because you, at least with the number of vaccines available, you have more people that you could be able to cover. And knowing fully well, or the children understanding that they will be pricked only once, the turnout is really encouraging, and we can see a vast population within a very short time. It's also quite cost saving, because though this GADASI4 vaccination or vaccines, they are free of charge as of now, the labor force or the people who have to go to the community, the nurses, the women's health nurses who have to go to the communities to vaccinate these children, it involves cost, paying for them. And with single dose vaccination, at least it helps the program to be able to manage costs, because you don't need to pay for people over and over going into the communities for vaccination, and we'll have better compliance. Just the fact that it is one shot that will be given, we have more parents and more children being vaccinated. But we have also noticed some challenges, which we could find on the next slide. We still have a lot of myths around HPV vaccines. And before 2021, when this GADASI4 was introduced into the expanded program of the API program of Cameroon, there were a lot of myths, because currently in Cameroon, for example, there's an ongoing armed conflict in the Northwest and Southwest region. And there was this belief that these vaccines could be coming in to sterilize young girls, because at that time we're administering the vaccines only to young girls. So there was this big question, why only girls? Why not boys? So that caused a lot of people to not allow their children to be vaccinated. And the turnout was really discouraging, especially in these two regions where there's a lot of instability. And the strategies to get people vaccinated in the rural and urban settings is not similar. The strategies that work in the towns is not the same thing that works in the rural settings. For example, in the rural settings, we still have the town criers who could go into the communities and hit the gongs and rally people around, come for a meeting, come for vaccination, and everybody turns out, but that will not work in the town. So that is a big difference in the sensitization strategy. We also have a lot of cultural barriers which exist. The northwest region of Cameroon, for example, as of now, has the highest turnout towards cervical cancer screening. And also, even though with the conflict, a lot of people in this region, they also allow their children to be vaccinated. But when you move like towards the south region of Cameroon, the cervical cancer screening uptake is still extremely very poor, and also concerns vaccination. So we find that there are some cultures that have not really embraced screening, they have not really embraced vaccination, and that really gives us a lot of duty to expand our sensitization strategy. Sometimes to get these vaccines from the government chain is a bit challenging, and we are following up to see how this could be resolved. Next slide, please. So to conclude, we'll say the strategy to lower these HPV related diseases, one of the most important tool or the most important key that we have to use is vaccination. We cannot be able to deal with these diseases if we are not able to immunize this young population. So we are putting in all strategies to work with stakeholders involved, both in the government and out of the government, to see that we can work hard to improve the vaccination in Cameroon using all strategies, using all avenues that we could use to fight these deadly malignancies that are finishing our population. Slide, please. This just illustrates some colleagues on the field. You could see a mixture of boys and girls turning out for the single dose HPV vaccination. With that, I come to an end of my presentation. Thank you for listening.
Thank you very much, Ngalla. We do have one question for you, and then Florence, there was a question outstanding for you as well for your presentation. So, Ngalla, would you like to answer? It comes from Alexandra Lindsay Perez. Said one of the slides mentioned a different vaccination protocol, single versus multiple dose, depending on whether the person is seronegative or seropositive. Are patients tested before being vaccinated? Over to you.
Okay,
Ngalla.
yeah, yes. Normally, according to the protocol, children who are seropositive, they're supposed to have the 3 doses. That is the normal recommendation. But on the field, we are not testing these children, but there is a way, there's an approach we could use to know a child that is seropositive, and that child normally will be given the 3 doses instead of the single dose.
I trust it answered your question, Alexandra. And then Florence, there's a question for you. Were there any conflicts with community-based health centers regarding the vaccination using church-based approach?
Thank you so much for this question. I just want to answer it in this way. In some of the communities that we visited, we didn't have a conflict with the health centers, but in some few communities, we had a conflict because the health center, especially the public health centers, they felt that using the church was like neglecting them or not giving much attention to the health of the people, since we had to do it in the churches. But before we went to any community, we had to get authorization from the regional delegates for vaccination for the regions and for the different districts. We had authorization, but while discussing with many of these people, they understood with us. But I remember in one facility, they refused us from vaccinating girls because they were not informed by the district medical officer, even though we tried indicating that we had authorization and trying to show, and see, they said since they didn't have authorization and they were not informed, we cannot do vaccination in this community. So that's how we left that community without vaccinating girls. But for the rest of the communities, it wasn't so bad. We were able to vaccinate without any conflict with the health facilities, especially the public health facilities in that area. I don't know if this answers your question.
Thank you, Florence. There's another question. I think we still have time. I'm not sure who it's addressed to, but it's please could you elaborate more on how you raise level of awareness in the rural regions for HPV vaccination? I think it's for you, Florence.
Yeah, thank you for the question. We like we have mentioned in our presentations, we have been working in both the rural and urban communities in Cameroon from 2007, and we have had different ways that we use to raise awareness. In most of the rural communities, at first we had a mobile van that when we take to the community, we pass around, and we use some microphones through the van. The van will equally make its alarm. Just making the alarm made people to know that something were happening, and especially in the rural communities, it drew many people to come to get know what we were talking about. And so through this process, we had flyers that we had to share to the community for them to get information about cervical cancer prevention, both screening and vaccination. We equally use the churches in these communities to sensitize the population. We have been using, if we go even to the mosque, we use other groups, social groups in the communities, especially in the rural communities. There are so many social groups. Some are dances, some are just maybe for their day-to-day activities kind of things. So we go through these social groups to sensitize, and maybe in some of the places, in some of those communities, there are people who have come from different localities and are based in that area. So they identify themselves in that area, and they have groups. So through these groups, we are able to screen, we are able to sensitize some of these people. So Calvin, I don't know if you can add some of the information on how we did the sensitization in the rural area.
Yeah, and we also, in the rare settings, we also visit people they call funds. The funds are like the kings of the royal communities to seek for authorization to be able to work in those communities. We also have quarter heads. Quarter heads are the heads of particular quarters, and the people listen from these particular authorities that are found in their environment. And I also mentioned about the issue of the town crier. The quarter heads and the funds, they send out town criers to speak in the language that the people understand. Because one of the things in the royal settings is the people want to align with their language. So if they could get health information in their mother tongue or in their dialect, their response will be better off than if we just speak in English language. So all those strategies have been helping us to be able to succeed in the royal setting, together with the ones that have been mentioned by Florence.
Thank you, Ngalla. I don't see any other questions. I think we could wrap up. Florence, unless you want to have another say. Thank you, everybody that took the time and effort to join this webinar. I trust you found it informative. And thank you to our speakers. It was very interesting, and we hope everyone will join our future webinars. We have another 2 webinars lined up, one happening in May. The date's still to be decided, but most likely will be in the last week of May. And it will be a 1-hour presentation, and it will be discussing several issues in oncology integrity, such as predatory publishing, data manipulation, plagiarism, retractions in oncology literature, and so on. And then in June, the Radiation Oncology SIG will run a webinar, and that will be focusing on hyperfraction. But of course, we have our flagship conference, and we invite you all to come, and we want to see you there in Senegal, in Dakar, from the 2nd to the 6th of November. I hope you'll be able to join us. There's still time for you to submit abstracts. Abstract submissions is open at the moment. Please do send abstracts, encourage your colleagues to send abstracts, and then registration will open in mid-May, I think it is, and there will also be opportunity to apply for bursaries to attend the conference. So hope to see you all there, and thank you once again to everybody for attending. It was a great turnout for a Friday afternoon, Workers' Day, but thank you so much for excellent presentations again to all our speakers. Thank you so much.
Thank you too very much. It was a great time here.
Thank you for the idea, Florence. Brilliant for your leadership.